Good morning, good afternoon, everyone, and welcome to this American Thoracic Society webinar on uh, training of critical care interprofessional team members in low resource settings around the world. I'm Neil Adhikari from the University of Toronto, and my co-chair is Dr. Juliana Ferreira from Brazil, and she's going to introduce our speakers maybe in just very shortly after a few more folks join the webinar. Thank you.
Thanks, Neil, for opening. Hi, everyone. I want to thank the Global Health Office at ATS for organizing this amazing webinar and the Education Working Group for putting it together. And obviously, thank our speakers for taking the time and being here. We have three speakers today. We have Dr. Theogene Teojiro Mugabe from the National University of Rwanda speaking first, then Dr. Burton Lee from the NIH. He's also the co-founder of the Critical Care Officer Program in Kenya, and Dr. Menbel Sultan, who is at St. Paul's Hospital in Ethiopia. Maybe there's people still joining, but I guess we should get started. So I'm going to invite Dr. Theogene to start his talk. Thank you so much for being here.
Thank you so much, Juliana. I think I'm going to start with sharing my screen. Super. So as you very well said, my name is Theogene Teojiro Mugabe, and I'm working at the University of Rwanda, the College of Medicine and Health Sciences. And I'm very happy and honored to be invited for this webinar on how to train intensive care provider in resource limited settings. I will give you a perspective from my country, Rwanda. Before we start, I have to say that I have no conflict of interest for this presentation, and my presentation will be a bit short. I will give you a little bit a background to support what I'm going to say here as my own opinion on this kind of training. And then I will emphasize on what kind of training should be provided to intensive care provider in low resource settings before I give a summary as a conclusion. So as Rwanda and any other country in Africa, we are very new in terms of intensive care practices, even though the very first intensive care unit has been opened in 1972 in the University Teaching Hospital of Butare, where I do work, but much of the practice were caring for post-operative care and trauma patient, and by archives, I didn't find any sufficient ventilators, and the ICU was almost run only by anesthesiologists, and there was no critical care nurses at that time. But later, after the 1994 genocide in Rwanda, some other hospitals, especially referral hospital in the capital, have opened the ICU, and the very last one has opened those by 2014. But despite those kind of efforts, the number of ICU bed and ICU capacity in terms of staff is still very limited, almost 100 times less compared to the developed countries. And this is a very known figure in terms of the capacity in the low-income country compared to upper middle and lower middle income countries. And Rwanda should be placed between the blue and maybe the orange line, low and lower middle income countries, as we still have only 53 ICU beds well equipped for 14 millions of the population. However, the number of critical ill patients is not lacking. We have run a study in my hospital to see how many patients will require or are eligible to be admitted in the ICU. And on our midway results, we found out that 10% of the patients we have in our hospital are eligible to be admitted in the ICU. Yet the capacity of the ICU is very low. Like almost out of 100 patients eligible to be admitted in the ICU, only 17% or 18% can be admitted in the ICU within the very first 24 hours, and let alone 27% during the hospital stay can be admitted in the ICU. That can explain why the mortality for critical ill patient is still very high, around 45%. The other thing is that when we analyze the number of deaths within the hospital, we see that in a total of deaths that happens in the hospital, 17 happens in the ICU, but 26% happen at the accident and emergency, which means that there is a lot of patients that are dying in the accident and emergency because of the lack of ICU bed or ICU care at accident and emergency. The same, almost the same number, even higher, happens in the internal medicine, which means that we do have a lot of patients dying within the accident and emergency and the internal medicine wards without access to ICU beds. There is also another reason that can explain that high mortality rate at accident and emergency in our hospital, especially in the health system in Rwanda. The health system in Rwanda is a kind of pyramidal shape where every single patient needs to get to the referral, should start with the peripheral hospital, starting from the health center, district hospital, before getting transferred to the referral hospital or university hospital where I do work. This critical time is very important in terms of management of intensive care services, and this can explain also the high mortality of patients that we see in our accident and emergency. And most of them will die within the very first 24 hours at the admission in the hospital. So this brings me to start on what is my opinion on who should be trained in the ICU. First of all, as a referral or teaching hospital, we've already ICU, which are very equipped. We don't have enough staff in terms of doctors and in terms of nurses. So to be able to meet the standards, we need to train a critical mass of intensive care providers as doctors, but also as nurses. Historically, and especially maybe for other countries in Africa and maybe in Europe as well, anesthesiologists have been playing a critical role in the ICUs. And I think we have to train during the residency of anesthesia. We needed to emphasize more on critical care, but also we are about to start a fellowship of critical care medicine, and which should include anesthesiologists, but also emergency physicians at the forefront of admission of those critically ill patients, and some internal medicine physicians like pulmonologists and cardiologists can also join. But for the nurses, we have already a training of emergency, critical care, and trauma nurses, but at master's level. My experience is that those who have a master's in critical care do not play a key role on the bedside. Most of them are occupying leadership positions or maybe managerial position, and can also be hired by learning institution. They don't contribute to the bedside teaching. So what I suggest is us to train rather senior nurses from A1 nurses, what we used to call advanced diploma for nurses, and those can gain a kind of bachelor degree with important skills and knowledge in critical care, so that they can play the role on the bedside for ICUs, but also at accident emergency department. But meanwhile, since I have shown that there is a huge gap of staff in existing ICU and the accident and emergency, we can also try to envisage some short-term training for general practitioners, that we used to call them, working in accident and emergency, because majority of the practitioners at the accident and emergency are general practitioners, but also in ICUs, because we cannot have all the intensivists and the anesthesiologists doing 24 hours, 7 days in ICU. So we need someone who can take care of the patient during the night and weekend duties, while the intensivists or trained anesthesiologists can cover at home or can be called when it is needed. Same for the nurses. We cannot train sufficient nurses to take care of critical ill patients in our settings. We need to have a kind of short term for the nurses. In our settings, like we have run a 6-month basic principle training of ICU for our nurses so that they can have a kind of certificates and be able to identify and monitor critical ill patients. That is what I can suggest. The other thing is that for those who are in the district hospital or peripheral hospital, as most of the patients are admitted when they are critically ill, they hope also to be trained on those that short-term training in basic principles of intensive care, but also in our context, since we still have more than 10% of our ICU patients being obstetric patients, I have also mentioned if we can also include the midwives. So, of course, the training, we are not going to invent the wheels, but we have to emphasize on some particularities in our related to our settings or to our local context. Because if you look at the case mix of patients we have, it's somehow a little bit different from what is seen from the Western countries. Though we may get a lot of from the curriculum that are run in Western countries, but we need to emphasize on the local context for different reasons, not only for the different case mix, but also some other particularities that I'm going to mention a little bit later on. But given the current situation, we are now facing a kind of epidemiological shift. We are facing a burden of non-communicable disease with a lot of strokes, a lot of myocardial infections coming. So we need to learn more and more from Western countries without forgetting contextualizing some of the training in our settings. In fact, the training of formal intensivists or intensive care providers in our settings should also equip them with some critical thinkings or some basics to be able to advocate for improvement of the ICU care in our settings, because it has been lagged behind because of more prioritization of primary health care. But as the example of Rwanda, it is the very first time that I see a strategic plan considering emergency and intensive care in my country. Maybe this is because of the experience from the pandemic of COVID-19, but we need to take that into consideration so that we can sustain the infrastructure and human resources that we are going to get from this strategic planning. So as I did mention that the training will emphasize on the local context for several reasons of case mix that is different, but also there are some evidence that guidelines that are implemented in Western countries may not very well work in our local context. This is a very good example of IV fluid management in septic patients, like in children in an East African country, where the too much fluid was increasing the mortality, but also in adults in a study that has been conducted in Zambia. The same findings, we have had the same findings in a kind of quality improvement project we run in our settings, where we are trying to see how we comply with the bundles of the Surviving Sepsis Campaign 2021 and train our local providers how we can improve. But we found out that more than 2 liters of IV fluid was associated with very high mortality, which means that what works in one settings may not work in other settings, which means that when we are training our intensive care provider, we have to emphasize on the local context, but also to raise in them a kind of critical thinking and the culture of having quality improvement projects in order to improve local context. So I did mention that for exactly for the formal training, intensivists, and when it comes to those who are going to bridge the gaps, the existing gap for the current situation, the short-term training should emphasize on the basic principle of critical illness, like recognition of signs of critical illnesses. Maybe for the doctors, we can also equip them with some skills for the resuscitation of major critical illness or syndrome, like hemodynamic management, respiratory, central nervous system failure management, and so on, and vascular access for those who are taking the night duty and the weekend duties in the ICU when the intensivist and the anesthesiologists in charge are at home to be accessed just when it is needed, and the airway management as well. For the nurses, simple as early recognition of the critical illnesses, like using of the simple triaging, but also the monitoring of critical ill patient can be something we have to start with. As a conclusions, as we did have much to do with intensive care management training in our settings, and also to try to meet the upcoming infrastructure, especially in our country where they are going to have much more intensive care infrastructure and equipment. We need to train a critical mass of specialists to meet those requirements, but those specialists should also be equipped with some skills for advocacy and the quality improvement programs, so that we can sustain the acquired intensive care facilities for the future. And for the training to close the existing gap, I did mention especially those nurses working at in emergency and general practitioners, but also practitioners at the district hospital and those working on the ambulances, which much emphasis should be on recognition of critical illnesses and triaging, early resuscitation, and the monitoring of critical illness, and know when and how to transfer a critically ill patient. I think that was my talk, and I thank you so much.
Thank you so much, Theo, for a wonderful presentation. We have questions at the end, so I'm going to invite Dr. Burtonley to give his talk.
All right. Well, thank you to ATS and the committee for inviting me. It's certainly a pleasure for me to give this talk. I'm super excited about this topic, so you will have a hard time maybe limiting this to the time allotted, but I'll do my best. So I'm going to complement what Dr. Theo just talked about by talking about increasing the supply of critical care providers in sub-Saharan Africa. I'm currently at the National Institute of Health, but I actually lived in Kajabi Medical Center in Kenya for about 6 years with my family. And during that time, we actually started an emergency and critical care clinical officer training program. And clinical officers, at least for the US audience, is closer to physician assistants. So they're neither physicians nor nurses, but that's the group that we chose to educate and train. So I think we're all familiar with pictures like this. This is actually showing the supply of clinicians around the world, where, relatively speaking, in much of the Northern Hemisphere looks quite obese in terms of clinician supply, but much of the South is the opposite. And again, we're all familiar with this, but there is a relative a scarcity of ICU beds. There's probably a greater scarcity, though, of trained clinicians in countries like Kenya. And so there are great examples of training programs. I'm sure our next speaker is going to speak more about that. But when I was there in Kenya, this program was already in existence in Ethiopia, but we chose to concentrate on clinical officers because the ratio to clinical officers to MD physician was 4-to-1. And so there was a relative abundance of people like that. And some of these people were super intelligent, super motivated, looking for the next level of challenge. So we chose to actually train the clinical officers. So our program is called the ECHO program. It stands for Emergency Critical Care Clinical Officer Program. And this is a photo of our first graduating class. And this is the curriculum for our trainees. When we first started, it was an 18-month training program, but it has evolved into a 2-year program because they also wanted to see more research and more contributions to the research literature. So I think it includes all the standard things that you might expect, including ultrasound and ACLS and ATLS kind of things, but also procedures and also mechanical ventilation. Just a quick granular detail. All of our curriculum is actually housed on Google Drive intentionally because all of that is free, and our trainees are expected to go through our curriculum in detail, and they compose of evidence-based summaries that is digestible for each topic, and then there's a series of questions that they need to be able to answer and master for each topic. So here's a picture of some of our trainees. That's actually my living room because they're all gathered there because that's where Wi-Fi was available at the time. I think it's gotten better now, but when I was living there, so they're all sitting in my living room or some part of my house, trying to take advantage of the Wi-Fi. Some of the milestones for our program, there's much to celebrate, in my opinion. We had our first graduating class, as you can see, of those individuals in 2016. And by 2017, we actually had formal approval by the Kenyan government. And, at least if you're familiar with sometimes how things can happen in this kind of context, we consider this actually a minor miracle that within a year of starting our program, we actually got an official approval to make this a formal track. And so now it is a formally recognized position. We have been training about 12 new trainees every year through the Kajabi College of Health Sciences. But one of our trainees actually was recruited by another training college in Nairobi. And so they train 14 people a year. And then because of the success of the adult ECHO program, now a pediatric equivalent has started recently. And so this is actually one of the conferences we held just a couple of years ago, where it shows, I think, close to 100 graduates who were actually gathered for a conference. And we expect to have trained about 250 individuals by 2030. So at least in our opinion, I think by focusing on the clinical officers rather than physicians, we're able to quickly expand the supply. Now, the challenge, what that remains, is actually ongoing support, because as the ECHO program expands, it gets more sophisticated. And so we are actually doing that through a group called Global Critical Care Collaborations. And we're trying to support the development and maturation of critical care medicine in resource variable settings. And we're trying to provide collaborative partnerships for both clinician and research capacity building. So these are our member institutions. It actually has eight high resource institutions. There's one in Nairobi, Kenya. It's in Nairobi, but it's a very sophisticated and high resource hospital. And then there are 7 institutions in the US. And we all collaborate together currently to support Kajabi Hospital, including the ECHO program. But we're also looking to expand to other places besides Kajabi once the program matures. And so we provide patient care support. And what we're doing is our member institutions are sending our fellows and attendings to Kajabi Hospital. And last year, we provided about 6 months of coverage and support. And the obvious thing here is that we're not trying to provide year-round support. We want to be supportive, but not to displace anybody. So we're there to actually complement what they're doing. We are also doing a lot of courses. So in addition to bedside teaching and lectures, we put on formal courses on ultrasound, mechanical ventilation, and even biostats and research methodology. And here's a photo of me and my colleague from NIH. They're actually doing the research methodology course and the mechanical ventilation course. So research, our goal is to have our own database that expands, but we just started a mentored research partnership with Kajabi Hospital, where the most promising individuals are actually paired with some of us from NIH or University of Pittsburgh, those in our consortium. And the goal is to have our African partners provide first author publications and primary experience doing research. And while our fellows are there for a month, our side goal is actually to provide protected academic time for our African colleagues, because I think, as many of you know, the desire for research is high, but there isn't necessarily time because they're so busy clinically. So our goal is to provide at least some protected time for that. I think this was a topic that was introduced by Dr. Theo, but this is an older article showing that less than, I think, 1% of the world clinical literature comes from Africa. And so we're trying to change that landscape, and there's a lot of enthusiasm at Kajabi Hospital for this. So I just want to thank our colleagues in Kenya and the US and elsewhere who are collaborating to both support the ECHO program and the Global Critical Care program. So thank you for your attention.
Thank you, Dr. Lee. I'm going to invite Dr. Mainbel Sultan for his talk now.
Thank you very much. Thank you, everyone, for joining and for inviting me. Thank you. It was a very interesting topic, so presented prior to my presentation. I'm going to present few experience from Ethiopian setting with multidisciplinary critical care training. So I'm going to present the experiences of St. Paul Hospital Millennium Medical College, where I am working, and Ministry of Health in my capacity during my advisorship for the ministry before 2 years. So I will be presenting briefly the background of Ethiopia and the critical care status of Ethiopia, and our fellowship program in intensive care medicine in my college, and short-term trainings in Ethiopia. So Ethiopia, as most of you know, it's an East African country with a population of around 126 million. And Ethiopia is a low-income country with per capita less than 1,000 USD. So Ethiopia is a low-income country, and 80% of the world is in low and middle-income country. So in also like other low-income countries, the incidence of critically ill patients is increasing, and epidemiologic and demographic shifts are occurring in our setting, like non-communicable diseases, trauma are increasing, and demographically, the life expectancy of the population is increasing. Like around 20, 30 years ago, it was 38 to 40. Currently, it is more than 65, like 66. So there is demographic shift. So there is a limited number of critical care professionals. Of course, before we start our fellowship program, critical care specialists or fellows, other than the pulmonology and critical care team, were 1 or 2. So that time, like 3 years ago, we had around 54 ICUs, and we were assessing those ICUs. So most of our ICUs were general ICUs, mostly level 1 to 2 ICUs, and their design and infrastructure is very poor, and even mostly they are not designed to be a critical care units. And we were assessing them using the international guidelines, and only 9 of them fulfill the level 2 status. The other were poorly designed, and 50% of them were having 6 to 5 beds, and few of our ICUs have more than 6 beds, which is difficult to allocate resource also. So we were looking for the availability of skilled professionals, and almost 50% of the the ICUs had no critical care trained seniors, and although those hospitals had adequate nursing staff, but those nurses also were not trained in monitoring and management of critically ill patients. And other specialists like respiratory therapy, physiotherapists are not available. So the nurses are expected to cover those professionals. Only 7 of those ICUs had academic activities, and 25% of staffs and ICU capacity is concentrated in the capital city, Addis Ababa. So we were planning to change that also. So epidemiologically, as I have said, injuries, non-communicable diseases are becoming common. And like recently from my ICU, almost 25% of the patients were respiratory failure, major head injury, and sepsis. 50% of the patients acquire this. The others, like pulmonary edema, hemorrhagic shock, obstetric complications. And the other is the mortality. In our centers, the mortality is high, around 35.5 overall mortality of ICU admission, and in some ICUs, it is higher. And you see, sepsis patients were almost 70% mortality for.
I think Nadal.
Did we lose Dr. Menbu here?
Yeah.
Okay, so maybe maybe we'll wait for him to come back, and in the meantime, we can move on to having some discussion.
Can you hear me now? Sorry for the interruption.
Hi, Dr. Menbu. Welcome back. We weren't sure how long you were going to take to come back, so we moved on to the discussion. But I think we'll let you continue and finish up your talk. Okay?
6 minutes.
Yeah, no,
Thank you
please,
very much.
please go ahead. Yeah, thank you so much.
Thank you. So did you hear about the epidemiology and some high mortality in our center?
I think we
Yes.
got cut off during that time. Yeah.
So thank you. So epidemiologically, as I said, 50% of our patients are young, respiratory failure, major head injury. Mortality is high in Ethiopia, with especially the septic patients and patients admitted from ward. And the efforts to improve critical care human resource is starting fellowship program in Ethiopia. So we have critical care, intensive care fellowship program, integration of intensive care training, as has been said, from Rwanda and Kenya, emergency medicine professionals. They're increasing their capacity in management of intensive care patients and internal medicine residents, anesthesiology, and there is.
I'm sorry, do you have slides? Do you want to re-share your slides with the group?
Okay. Sorry. What about now? Can you see it?
Yes. Thank you.
Thank you. So fellowship program in pulmonology and critical care medicine, and there are short-term training programs for staffs working in ICU and emergency, and mentorship and coaching program. So intensive care fellowship program in my college, St. Paul Hospital Millennium Medical College, we started because there is in Ethiopia there is a roadmap for specialty and subspecialty, and it says tertiary care center should have intensivists, but we don't have college for intensive care training. Limited number of critical care professionals, and so as you know, well organized and trained professional will decrease mortality, and there are like improvement in trainings in other subspecialties like cardiology and other subspecialties. So we need to support with fellowship in critical care. So we did need assessment to assess the need for intensive care medicine, a cross-sectional study involving different organizations and professionals. So the result shows there is a high need for intensive care subspecialty fellowship in critical care, and they also think critical care fellowship improves the outcome and critical care fellowship status in Ethiopia. So we moved to with development of the curriculum for subspecialty adult intensive care fellowship training program, and we've started it 2 years ago. The first batch will graduate in September, and so with the objective to produce a competent professional who can provide advanced care leadership role and conduct research work for intensive care. The first program, it is a 2 years program and 24 months. At the first year, we had 14 applicants, and 4 of them were enrolled. In the second batch, 3 of them were enrolled. So now we have 7 intensivists in my college. And the candidates were internists, anesthesiologists, and emergency and critical care physicians. And this combination also helped for peer learning. So the fellows will learn each other. So the anesthesiologist will teach the others about advanced airways, and internists will teach the medical part to their colleagues. So this was a good combination. So the teaching-led learning method, mostly the usual teaching learning method like clinical discussions, mortality reviews. So they spend most of their time in ICU with, this is the typical week in this fellowship program. So morning sessions, rounds, family counseling, seminars, like coursework will have a presentation by consultants every Tuesday, and we have quality ed audit, fellow seminars, journal appraisals. These were the typical week for our fellows. And these are the modules like respiratory module, cardiovascular module, pulmonary polytrauma. So these modules will guide us to focus in what topics to focus in seminars and lectures during their 2-year stay. So we have gastrointestinal obstetrics. So this will guide us the focus of area in during each month. So we have also need-based rotation for our fellows, like anesthesiology attachment for internal medicine or internists, and those coming from anesthesia will have attachment in emergency medicine. The others also will have pulmonary medicine, cardiology, and nephrology attachment. And there is a 3-month exposure at Indian St. John's Hospital in Bangalore. So they will be attaching in that hospital also. We have collaborations with virtual session from a team in Canada. So I would like to thank Dr. Neil for his continuous support for this program and their attachment in St. John's and the St. John's Medical College and Johns Hopkins in US. So we plan to probably we may expand this program to other universities. Addis Ababa University was starting this program and planning to continue this program, and we will evaluate our program. There are also short-term programs, mainly funded by Ministry of Health. It involves hands-on training for junior doctors, nurses, and anesthetic nurses. It is a 21 days training organized by Ministry of Health, and the other is mentorship and coaching. These are the objectives for short-term training, like diagnosis and management of respiratory failure, documentation ICU, utilization of critical care equipment, monitoring, transportation, setting a new ICU, management of sepsis. These are like BLS and SLS. These are the objectives of the training, and they will have exposure in bigger ICUs in the capital city, like our ICU and ICU at Black Lion Hospital. It is a 3 weeks training. It's funded by MOA, so it has helped to improve the capacity of the low-level professional. So mostly they plan to give training for 150 professionals and to improve patient care, reduce mortality rate, and enhance healthcare delivery. So the other program from Ministry of Health is the mentorship and coaching program. So the rationale for this mentorship and coaching program is most of the healthcare human resource is concentrated in capital cities. So they are assigned to the lower ICU so that they can support the lower ICUs. So identify area for improvement, especially national level, possible growth to spoke and hub. So local hospital, hub hospitals are mentoring the spoke hospital, and so previous mentorship also has improved. These are the activities by the senior physician who are assigned to the lower ICUs. Like they observe and identify gap and assist to solve the problems, and daily monitoring and teaching sessions, make educational session, and mainly they are working with the management team so that the improvement will be fastened. So they do daily round, and they shadow while the local team is working, and quality assurance audits with sample charts. So mentorship and coaching has improved. We've published the impact of mentorship and coaching. It has a good impact because most of our staffs are concentrated in capital cities. I know it's a short time and the notes also short. Thank you very much. And I may explain during the question and answer. Thank you. Back to you.
Thanks so much, Dr. Sultan, and to all of our speakers. You can feel free to stop sharing your slides at this point in time. I think we'll move on to our discussion period now, and for those of you that have joined the webinar, there's a question and answer box at the bottom. Feel free to put some questions if you have any into that box, and we'll try to address them in the next 15 minutes or so. I wanted to ask each of our speakers around a topic that really all of you have touched on, and this is to do with training of or developing acute care expertise outside of referral centers, since most patients are initially cared for in either primary health centers or district level hospitals. And each of you have touched on this topic. So I guess I'd be interested in hearing from first of all, Dr. Twari Mugabe, about how he thinks, how you think that Rwanda is handling this issue of trying to, I guess, spread the wealth of knowledge to where it's needed most. Dr. Lee, if you could, I'd be very interested to know in what the ECHO program graduates are actually doing. And Dr. Sultan, I'm very interested. It sounds like Ethiopia has recognized this as a problem, and I'd be interested in knowing what the graduates of that short course are doing, and whether your sense is that it's long enough of a training period to really have an impact on those folks. So maybe, Theogene, if you wanna speak first, feel free to go ahead. Thanks.
Thank you so much. As I did mention, we don't have enough, or we have never had enough critical care nurses, either in a referral hospital, in the ICUs, but much gap are in the district hospital. That is why we see a lot of patients that are transferred in a very critical condition to die at the accident and emergency. So one approach that I can envisage is to train those nurses and some general practitioners in those hospitals with the short-term basis, giving the basics and some recognition of danger signs and how to manage them and when to transfer. To make it a little bit effective, I think Rwanda, we have been successful in doing what we call performance-based financing. So like we can have a kind of algorithm, and those who perform well in transferring on time, those kind of patients can get extra funds for the hospital, but also for the staff in terms of the salary and the career paths. And we have tried this for maternal and child health. We have tried this in management of the HIV. I think there is no reason that it can't work for us.
Great, thank you. That's fascinating to hear about economic incentives to improve care in this kind of setting. Burton.
Yes, I think that's a very good question. So I think our rationale for actually starting our program in Kajabi Hospital is because it's actually not urban. It's about an hour and 40 minutes or so away from Nairobi. And yet it's a sophisticated enough hospital to support a training program with volume and expertise. So for example, the hospital has already had residency programs in general surgery and orthopedic surgery. We have a neurosurgeon, et cetera. So there's a need for an ICU, and there is a lot of volume. So I think it's the balance that we were looking for, but we also didn't necessarily want to be centered in Nairobi, where there are actually quite well-funded hospitals also, where that's all they're going to do. is very, very high-tech stuff that may not be applicable for some settings in Africa. So, and then as far as what they're doing now, it's actually a spectrum. Some have stayed on at Kajabi Hospital itself, but more gladly for us, actually, many have gone to many of the much less resource places than Kajabi Hospital. Some are out in, like in northern Kenya, for example, but others have actually pivoted and are working as, I think, as like perfusionists, for example, for a like for cardiac surgery program, because their background allows them to actually fill in roles that may not have been previously defined in Kenya. So I think there's a spectrum, but the vast majority of them are actually practicing outside of Kajabi itself in much more resource limited context.
Great, thank you. And Dr. Mendu, yeah.
Thank you for your question. Thank you very much. So the short-term training, we've tried the 3 weeks and 6-week training. The 3-week training is more effective, but impact-wise, we were unable to assess the impact of the 3-week training. Just subjectively, qualitatively, the participants said it has improved our knowledge and skill. But we have done the impact of mentorship and coaching. We are assigning experienced physician from Addis to the low-level hospital so that they can mentor, train, and coach on-site. So that has a huge impact in improvement of their skill and overall improvement of the ICU. Because they are working with the management team, they have improved. We were evaluating the 12 parameters of the ICU status from the International Society of Intensive and Critical Care. Most of it has improved. The structure, the skill, and the culture of that ICU has improved with mentorship and coaching. Of course, the short-term training also has improved their skill. Objectively, we haven't assessed how much it has helped, but more than 3 weeks, detaching the participants from their workplace didn't make effective training. Thank you very much.
Thanks. It's fascinating to hear from each of you about 3 different approaches to sort of improving diffusion of critical care expertise outside of expert centers. And I appreciate the last point you made, that in your particular context, that having training that's too long actually is a bit of a problem because it takes people away from their workplace. Juliana, as someone who works in not in Africa but in Brazil, I'd be totally interested to hear your reflections on challenges of training in that context. Thanks.
Thanks, Neil. I think I share some of the experience from Tio and Membu, and also what Burton mentioned about Nairobi. Brazil can be very unequal. So there hospitals where I work, I think the country has focused on training people through formal programs that look like what is a fellowship program in the US or Canada, but in Brazil they're called a residency as well, but a 2-year program funded by the federal government to train mostly physicians, but also there are programs for nurses and physiotherapists. But most of the spots are in bigger cities, the capitals of the states, and you have less offer in smaller places. And also for critical care, we had 25% of the spots were not filled. So we had more spots than people interested in the spots. And of course, that happens in smaller centers and smaller hospitals. So I think the biggest challenge, and something that also fascinated me about Theo's comment on the government providing incentive, I think without public policy, that becomes very hard to be done. You need a centralized strategy to attract people for training, and then also the fellowship, the scholarship, how much they get for being in a 2-year program is in Sao Paulo, for example, not enough to live close to the hospital, for example. So most of our fellows work in their free time in other private hospitals to compensate. So improving, thinking of planning where you want to train people and attracting clinicians to these programs, I think is very important. And it looks like giving incentives to attract people to get trained in smaller places would make a big difference.
Great. Yeah, thanks very much. It's a very complex issue about this issue of training. You clearly have some people that are passionate and they're drawn towards critical care, and there are other people that are a bit more undifferentiated, but could choose critical care under the right financial and mentorship contexts. It's about switching the needle to try to get folks to choose that as a pathway. We've got some questions in the chat, and so thanks, folks, for putting your questions in the chat. We've got a bit of time. We'll maybe address some of them. The first question is from a participant who is asking if any organization is giving and providing support or scholarships for African healthcare professionals training in critical care outside of their countries with the aim of returning to provide critical care services back home. And the person comments that there doesn't seem to be funding for critical care training within Africa compared to other areas of study. Any comments on that? And maybe maybe I can start, and William and Burton and Juliana might have some comments from the higher income perspective here. I think I'm actually not aware of, at least within Canada, of sort of scholarships available for support, but some hospitals in Canada, including the one where I work, run fellowship programs in critical care medicine to which international applicants can apply. But those international applicants include folks from everywhere, and it can be a difficult transition for someone who's worked in particular in an African context, but basically a non-Canadian context, to come and to gain enough in a year, because you often spend the first 6 months just getting used to the system, which has its own quirks and characteristics that are, that may not be rational, but that's just the way it is. So, and we have had trainees from Africa and Asia, from non-high income countries come, but it's definitely each of them it's a very challenging pathway from both from the regulatory point of view and then from the personal experience. But folks that do come have in many cases gone back and contributed to care back home. Interested in others' thoughts on that.
I can add that I have Brazilian friends who have gone in trainings like that, but most of them have not returned to Brazil. So that would be something I would also worry, that if people do all the work that you mentioned, the hard work of adapting and taking all the steps to be accepted in that program, and if that contributes somehow for people not returning to their countries, which is something we would worry about as well.
Yeah, and I don't know about an interinstitutional program. We don't have one here in our hospital institution, and I haven't heard of others. Burton, do you know how is that kind of an inter-country and interinstitutional exchange? Is that something that is or could be supported by NIH?
Yeah, I think it's a little tricky because, like, at least in the U.S. context, if somebody tries to come, it's hard without, U.S. residency training program and so forth. So there's a lot of logistical barriers. But I agree with Juliana. I think the biggest concern for me would be whether they go through multi-year training in the U.S. or Canada, but then, maybe not return to their country of origin and then you would contribute to the brain drain issue, I guess.
Yeah, I think I do agree that that's a crucial issue. Actually, for fellowship training, it's actually easier, we hear, for fellows to come to Canada than the US because of the lack of a requirement for residency training in Canada. I think actually the program that Dr. Menbu outlined, where trainees have a 3-year attachment in India, strikes me as a quite elegant solution to this issue. And maybe you can comment, Dr. Menbu, on your thinking around placement in India for your trainees, because I think it's quite smart and helps to address some of the issues of concerns about brain drain.
Thank you very much, Dr. Neil. The concern is real. Most of our fellows who went to the either the US or even Canada, they didn't come back, most of them. And I have seen the epidemiology of diseases and even the demography is not the same. The low-income country like Ethiopia and the Eastern African country and the Westerns, totally the epidemiology is different. Communicable diseases are not common in Western settings. Older populations are being managed in Western settings. But the same epidemiology is being managed in India and some Asian countries. So epidemiologically is good. Participant will come back most likely to their home country. And cost-wise, it's also cheaper. So that is why we chose to send our fellows to India for their exposure. The plan was to send them for more months, but due to financial reason, we have intensive 3-month training. And the Indian team also come in person to train them to Ethiopia, so that they will get a good exposure from experienced faculties, and they will follow them when they are attaching their program in India. So we found it better to send our fellows to India and some Asian countries rather than to well-developed countries. Thank you.
What I can say is that there are some possibilities to train in critical care in France. There are some slots that are open, but to the world, so which means that it is very, very competitive. But as much as I did say, the commitment of the government is needed. And in that way, if a university or training institution in a low-income country can partner with a university teaching hospital in France, they can offer that possibility to have an exposure from 6 months up to 2 years, to have a kind of blended training, which can give an opportunity to get exposed to very well settled intensive care units, but also keeping in mind the local context. And I think from that, we can have a very well-trained and capable intensivist in our context. But of course, it's only France. No other countries do accept that kind of training so far. Thank you.
Great, thanks for that. We have a couple more questions in the chat, and the next one, I guess, is specifically directed to Burton. It's the questions points out that the ECHO programs really achieved great things, but Kenya's now generating a lot of medical graduates, and wondering about opportunities for training of physicians in critical care. Does ECHO foresee expanding to that cadre of healthcare worker?
Yeah, that's a great question. And I am aware of more medical schools having started in Kenya in recent years. There is now a emergency medicine residency training program in Nairobi, and there's also now a critical care training program in Nairobi as well. These are more recent efforts since we started the ECHO program. But I think in terms of the number of years it takes to train a residency trained physician, if you start from medical school onward, it's many more years than it is for the ECHO program. So I think they will probably continue to coexist for at least for the foreseeable future. Yeah, but I think both are needed and are welcome.
Great, thank you. We have maybe a few more minutes. The ATS wants us to close by 7 minutes from now. I did have a question for Dr. Theo and Dr. Menbu, and that's what your thoughts are about having sort of regional training programs within Africa. So for physicians, and I know we're talking about this is meant to be multidisciplinary, but since both of you are physicians, maybe I'll get you to focus on physicians, but feel free to talk about nursing training as well. So in other words, Rwanda having trainees coming from nearby countries, Ethiopia similarly, do you think there are opportunities there? Does the government see that? Do governments see opportunities in regional collaboration? So thank you.
Thank you so much. Actually, we have already started to draft the curriculum for fellowship in critical care medicine, and we need support from neighboring countries and country in Western region like yours to support that training. And much of the trainees will be already accomplished anesthesiologists, but also we are trying to include emergency physician because we have a resident training for emergency and critical care, but the critical care exposure for those emergency physicians is very limited. So if we can help them accomplishing a fellowship in critical care, that can increase the number of intensive care providers. As I did mention, we already have a training for nurses, but it's a master's in emergency trauma and critical care. As I did mention, the challenge that we have for those who have already graduated, no one is at bedside of the patient, so we still face the same challenges. So most of them are administration, or they have stayed at the institution for teaching other colleagues. That is why I did mention maybe we can see that on the other side in enroll rather A-level nurses to give them a kind of bachelor degree with a great emphasis on critical care so that we can expect them to be on bedside teaching and but also on bedside practice. This can make a huge difference.
Yes. Thank you, Dr. Neil. This regional collaboration, it has been tried and it is effective. Some of the countries like Kenya may have a better thing in some way. And it's also good for to get the support from Western countries like yours. So we've tried in pediatrics, one of the fellow came from Rwanda, and it helped to enhance the collaboration and the support from West. And the other, our program, our fellowship program in intensive care and the Ghanaian intensive care fellowship program almost started at the same time. And Johns Hopkins University, the team from Johns Hopkins is collaborating in organizing weekly seminars. So they are doing international critical care fellowship seminars every week. So that makes the collaboration of Ethiopian fellowship and the Ghanaian fellowship improved the interest of the team from US to make their presentation weekly. So the collaboration is possible, and it is being done now, and it's helping a lot to effectively use the resources. Thank you very much.
Great. Thanks to both of you. Just in the last couple of minutes, there's a question here from a physician in Mombasa, Kenya, who wanted to know how their medical officers could be linked up to the ECHO program in Kajabi, which is a very granular question, but I think we should try to answer people's granular questions. So Burton, maybe you can comment.
Yeah, I mean, I'd be happy to connect you to the right people. If you want to send me an email, I could put that in the chat, I guess, if you just want to contact me. Yeah, but I think like the trainees come from all over Kenya and some beyond. So yeah, you'd be welcome.
Great. So I think that's all the questions we have in the chat. I wanted to take 30 seconds just to follow up on something Dr. Theo said on the issue of training nurses through the university system where they get master's degrees and then completely leave the bedside. I've seen that also in Ethiopia. I think hospital-based practical training that is recognized as important and paid appropriately is so important. And I don't think that nut has been totally cracked yet, but I hope that it will. We gotta keep enthusiastic nurses at the bedside and not train them in a manner that leads to incentives to leave the bedside. With that, I think we're just about closed, and the ATS wanted me to remind everyone that there will be a recording of this webinar made and posted on YouTube, and I believe it's going to be sent by email to each of the participants. And I'll let Dr. Juliana close with a plug for the next webinar in this series. Thanks very much to everyone for attending.
Yes, thank you so much, Neil, Will, and the speakers for being here. We had a fantastic discussion and fantastic presentations. And there's an upcoming webinar also organized by the International Health Committee at ATS that's programmed for September. So stay tuned to ATS emails inviting for that webinar, continuing with the idea of discussing important topics in critical care and global health within the ATS community. Thank you so much, everyone, for attending. I'll see you in September.
Thank you so much.
Thank you very much. Thank you.